Welcome to Shoulder Function and Dysfunction in Overhead Athletes. We will explore evidence-based examination and treatment of scapular dysfunction and scapular dyskinesis as a major contributor to shoulder impairments in overhead athletes. This course content was authored by Ali Jaffrey. Dr. Jaffrey earned a Master's of Science in Physical Therapy in 2002 from the University of Connecticut and a Doctor of Physical Therapy from Regis University in 2013. He has 11 years of outpatient orthopedic and sports medicine experience. Dr. Jaffrey is a certified strength and conditioning specialist and holds an orthopedic manual certification from the Ola Grimsby Institute. He has also earned an orthopedic clinical specialty certification from the American Board of Physical Therapy Specialties. Upon completion of this presentation, the participant will be able to describe scapular function, scapulohumeral rhythm, and related force couples, relate scapular anatomic and functional concepts to the overhead athlete, discuss the impact of recent research on scapular dysfunctions on the overhead athlete, describe at least 3 evidence-based scapular examination procedures for the overhead athlete, and identify at least 3 key interventions in the treatment of scapular dysfunctions in the overhead athlete. The scapula performs 3 major roles. In terms of glenohumeral kinematics, the scapula maintains congruency between the humeral head and the glenoid fossa through dynamic stability with controlled mobility. The scapula also provides a stable base for optimal muscle activation. This allows the optimal muscle length-tension relationships for efficient rotator cuff function. Finally, the scapula is also a transfer link for the kinetic chain. It is pivotal in the proximal to distal energy transfer of large forces from the leg and trunk that are delivered to the arms and hands, making it an important component for effective overhead activity and forceful overhead athletic motions. Scapular motions consist of the following: elevation and depression in the frontal plane, posterior and anterior tilting in the sagittal plane, upward and downward rotation in the frontal plane, protraction and retraction in the transverse plane, and internal and external rotation in the transverse plane. Medial and lateral tilting would be examples of this particular motion. While there are many muscle actions that influence the scapula, the 2 primary scapular muscles we will focus on are the trapezius and the serratus anterior. The upper trapezius elevates and upwardly rotates the scapula. The middle trapezius is involved with scapular retraction, and the lower trapezius depresses and upwardly rotates the scapula. Later on, we will discuss the significance of lower trapezius dysfunction in scapular dyskinesis and lower trapezius strengthening strategies. The serratus anterior is involved with scapular protraction and upward rotation. More specifically, the lower fibers of the serratus anterior draw the inferior angle of the scapula forward to allow for upward rotation. As we will see, this trapezius and serratus anterior force coupling for stable scapular upward rotation moves the coracoacromial arch out of the way for the greater tubercle during overhead activity. Since the scapula lacks notable passive constraints, such as ligaments or osseous-related joint congruency, scapular stability is dependent upon appropriate neuromuscular control factors. In other words, it is the neuromuscular system holding the scapula in place. This is accomplished through balanced force production between protractors and retractors, providing medial and lateral stability, balanced muscle activity for all 3 trapezius parts, providing rotational support, and balanced timing of muscle recruitment among scapular muscles, rounding out the neuromuscular support.